never been to. It's wonderful. His name was Francis Fontaine. And he is the way you're picturing him right now is exactly the way he is. Tall, gray hair, charcoal gray suit, okay? Pretends not to speak English, but does, okay? And he said, you know, these right ventricles are obstructed and they're terrible. They're never going to be used. He said, but I think if you diverted all the blue blood in the heart directly to the pulmonary arteries, I think if the rest of the heart is normal, the blood she will flow. Okay? So here's how we do this operation now. Connect the superior vena cava to the pulmonary arteries. Take the inferior vena cava, route it to the pulmonary arteries. So now you have all the blue blood flowing to the lungs, just like in your heart. And amazingly, it works, and the kids do well. Not perfect, but well. If I took you to a schoolyard and said, there's 100 kids here, find the 5 who've had this operation, you couldn't do it. They're pink, 95% saturated, running and playing. So a major, major advance, the Fontaine operation for congenital heart disease. Okay? We don't do it at birth. At birth, we'll do the shunts. We'll do this at about 1 or 2 years of age. The Fontaine operation, and sometimes we do it in stages. Okay? Fontaine procedure. Tetralogy of Fallot, guarantee for the boards. Okay? So 10% of all congenital heart disease. What do we have going on here? We have a ventricular septal defect. We have right ventricular hypertrophy. We have the famous overriding aorta. The aorta hangs halfway over the right and left ventricle. And what's causing the murmur, the loud, harsh systolic murmur, and causing the cyanosis is this obstruction under and sometimes at the pulmonary valve. There's pulmonary stenosis. Blood can't get out to the pulmonary artery, so it goes out the aorta through the VSD. That's why there's cyanotic. Okay? Harsh murmur. Single second heart sound. Cyanotic. Remember the association between squatting, okay, clubbing and squatting babies with tetralogy of Fallot. Rare now because we don't let kids get to be 5, 6, 7 years of age without repairing them anymore. On the EKG, right ventricular hypertrophy, right axis deviation. And here is the famous boot-shaped heart you've all been waiting for, okay? All right, you happy now? All right, boot-shaped heart of tetralogy of Fallot. By the way, uplifted apex, that means right ventricular hypertrophy, okay? Usually a complete repair is done at or before 6 months of age now. It's really cool. So the repair consists of closing the VSD, can be done easily. See me doing it? I can do it, okay? And then reaming out whatever obstruction is at or below the pulmonary valve, and you're done. Repair of tetralogy of Fallot. It's been done for decades and decades and decades, okay? Know about the tetralogy spell. Before surgery, when we used to let the kids get a little bit too old, they would wake up in the morning, very hyperpneic, cyanotic. They would get themselves into a knee-chest position. They were having a cyanotic spell. And before the days of congenital heart surgery, the mothers would just put the kids to bed and hope they woke up, in a few hours. If you're faced with a child in the emergency room with tetralogy spell, knee-chest position, lots of fluids, morphine can help, bicarb can help, phenylephrine can help, a beta blocker can help. I just want you to know the association of tetralogy of Fallot with the tetralogy of Fallot spell. And in today's world, if we see a kid with a spell, it's surgery time. Period, end. I don't care what age. Okay? Okay. So those were the heart defects that have cyanosis and diminished pulmonary flow, obstructed flow. Now let's talk about those congenital heart defects that present with cyanosis. That's the presentation. That's the phone call you get, cyanosis. But when you look at the x-ray, they have normal or increased pulmonary flow. And the granddaddy of all and the most common of all is transposition of the great arteries. Typically in males, but obviously can be anybody. Loud single second heart sound because the aorta is right under the sternum. Okay. Very often no murmur. And here's your egg-shaped heart. I know you've been waiting for the egg-shaped heart. Okay. And on EKG, right ventricular hypertrophy. Let's look at transposition. Here's what's going on. You have two circulations in parallel. So all the blue blood is going through the right heart aorta back to the right heart. On the other side of the heart, bright red blood coming back from the lungs, going to the left ventricle and back out the pulmonary artery to the lungs, okay? There's got to be some communication mixing between these two sides of the heart for these babies to live for 5 minutes after birth. Ductus can help a little bit, but it's usually not enough. Okay? So if you gave a baby prostaglandin and they improved a little bit, it would be a good thing to do. Okay? But this is where we come in. This is a cardiology emergency, and we will do the famous Rashkin atrial balloon septostomy. Take a catheter, get into a femoral vein or umbilical vein, up the inferior vena cava, right atrium, get it through whatever little foramen you can find. I've always found one. Blow up a balloon, and then tear the atrial septum, the septum primum, to be precise. Once you've created this atrial defect, now some blue blood can get over to the left side of the heart to go to the lungs and get some oxygen. Some of the red blood coming back from the lungs can get over to the other side, right ventricle and aorta. Dramatically improved the prognosis of transposition of the great arteries. Before Dr. Rashkin described this procedure, they all died. After Dr. Rashkin's procedure was described and he showed that he could save these babies, it became the surgeon's problem to figure out what to do next. Here's what we do in today's world to repair transposition. We put the arteries where they're supposed to be. Okay? Do it at about a week or two of age. They tried that 40 years ago. They couldn't do it because they couldn't figure out how to move the coronaries also. So while this was obvious what had to be done, they couldn't do it for many, many, many decades. So let me show you what they used to do. And thousands and thousands and thousands of young adolescents and young adults have had this surgery performed. They couldn't do the switching. But what they could do was open the atrium, take away whatever atrial septum was there, and throw it out. And then they would sew in a complex baffle within the atrium. Look at it. All of the blue blood coming back from the vena cava, well, let's start with the red blood. The red blood coming from the lungs goes to the left atrium, to the right atrium, right ventricle, and aorta. Oh, bright red blood going to the aorta. That's cool. If you cut this baffle in the atrium and looked underneath, you saw all the blue blood coming back from the vena cavas going to the left ventricle, out to the pulmonary artery to get oxygen. Okay? If you did it with artificial fabric, it was called the mustard operation. Anybody ever hear that? Okay. If you were a real clever surgeon and just folded in the atrial walls to make the two tunnels, that was called the Senning operation. Same thing. Not a great, well, it was a great operation. Okay. Again, I mean, we just graduated a medical student who had this done. The problems, a lot of surgery in this area. Watch for sick sinus syndrome, sinus node area. A lot of surgery in the atrium, atrial arrhythmias. Remember I talked about atrial flutters? Okay? And when all is said and done with this operation, even though these kids look perfectly normal, if you took it to the schoolyard and said pick them out, you couldn't, you still have a right ventricle pumping out an aorta, and nobody's confident that that can go on for 70, 80 years. Okay? But you need to know about this because there's thousands and thousands and thousands of folks who have had this operation. But today's operation, I want you to remember the famous arterial switch procedure. Great. Continuing on our journey of congenital heart disease that presents with cyanosis that has normal or increased blood flow on the x-ray, we have to mention truncus arteriosus. And because it's rare, it'll be on the boards, okay? All right? All right. Truncus arteriosus consists of a big ventricular septal defect, and one big vessel comes off the heart which divides into the aorta and to the pulmonary arteries, okay? And this leaflet of the truncus often has 4 or 5 valve leaflets instead of just 3. And often has a right aortic arch. Look at the right aortic arch here. Okay? If the pulmonary flow, like in this case, looks pretty unobstructed, minimal cyanosis. Maybe a little rapid breathing, actually, because of too much blood flow going to the lungs. On exam, a click. You may hear a little click on the sternal border, which is this truncus valve opening, snapping, opening up. EKG, biventricular hypertrophy. What I'm really showing you this for is to remember the fish test for truncus arteriosus. The deletion on the long arm, chromosome 22. The repair is done at about 6 months of age. Close the ventricular septal defect. Ventricular septal defect is patched. The pulmonary artery is cut off of the truncus, And a tube, a conduit, is run from the right ventricle to the pulmonary artery. That is the Rastelli operation, repair of truncus arteriosus. Outstanding. Finally, I have to mention total anomalous another one of the T's, right? Total anomalous pulmonary venous return. And what's happening here is pulmonary veins are coming behind the left atrium. They want to go into the left atrium. They don't quite make it. They get diverted somewhere else. They can get diverted here to a left-sided superior vena cava. They can get diverted to a coronary sinus to get to the right atrium. Or in the newborn presentation, they can get diverted to a vein below the diaphragm, get pinched as they try to enter the inferior vena cava to get to the right atrium. If the venous return is unrestricted, unobstructed, and if it goes to the left superior vena cava to get back to the heart, you get this snowman kind of appearance of the heart. This is the dilated left superior vena cava carrying the pulmonary venous blood back to the heart. But know this presentation. Good stuff for the boards. Newborn born, respiratory distress, pulmonary edema. This is very likely to be pulmonary venous return below the diaphragm, infradiaphragmatic, into the inferior vena cava with obstruction. Urgent surgery is required to connect the pulmonary veins back to the left atrium. Finally, I just want to mention when we talk about cyanosis, complex heart defects, double outlet right ventricle, where both the pulmonary and the aorta come off the right ventricle, or single ventricle, there's one major ventricular chamber. Don't worry about these, okay? All I want you to know is that the degree of cyanosis for these defects depends on the amount of pulmonary stenosis that might or might not be present. Lots of pulmonary stenosis, loud systolic murmur, cyanosis. Not much pulmonary stenosis, minimal cyanosis. That's all I want you to know. Surgical repairs, complex, at about a year of age. Okay? New topic? Almost done, guys. You're doing all right. Hanging in there. Remember I said that left to right shunts, if they are going to present with symptoms of heart failure, it's about at when? 4 to 6 weeks of age. I'm now going to teach you what to think about when a baby presents within the first few days or week of life with heart failure. Newborns presenting with heart failure, poor pulses, poor perfusion, big livers in the first week of life, think obstruction to left heart flow. That's what causes heart failure in the first week of life. What am I talking about? Here's a coarctation. If tight enough, it causes baby heart failure. Okay? Easy to diagnose. Feel the pulses in the arms and the legs. Okay? If it's tight enough, baby heart failure. If it's not that tight, hypertension in a child or a young adolescent or a young adult. Okay? Treatment of coarctation and left heart obstructions. Open the ductus, because here we have a very serious coarctation. Even if this was a total interruption of the aortic arch, like in this case, if you were to open the ductus, you can get blood flow to go from the pulmonary artery to the ductus, down to the descending aorta, perfuse the kidneys, perfuse the mesentery, and make the child non-acidotic and much, much, much better condition. So don't forget the use of prostaglandin in the treatment of severe left heart obstructions in the newborn period. Okay? And what test would you order in a child with a true interrupted aortic arch? Here's the ascending aorta. There's the descending aorta. Fish test. Okay? Don't forget that. Finally, the granddaddy of all obstructed left hearts, you've all seen this, is total complete hypoplasia of the left heart. Baby's born, does great, and then on hour 4, 5, or 6, cardiovascular collapse. Yes, think sepsis. Yes, think metabolic disease. But if you don't think about this, you're probably not going to be right. And that is hypoplastic left heart syndrome. No aortic valve, almost no left ventricle, no mitral valve. And when I was a fellow, there was nothing we could do about this, and the only option was to let the baby die. A surgeon in Loma Linda, anybody from Loma Linda? Leonard Bailey did transplants, transplanted hundreds and hundreds and hundreds of babies, okay? And good news, after Leonard's done with you, you have a normal heart. The not so good news is you're on steroids, cyclosporin, et cetera, et cetera. The other bad news is that there's not enough donors, even if immunotherapy was perfect, to provide hearts for all the babies born with hypoplastic left heart syndrome. Anybody know Paul Simon's Graceland album? Anybody know that album? Oh, we got a couple. It's a great, the rest of you ought to get it. It's terrific. In the opening number, he talks about the baby with the baboon heart. That was Leonard, okay? Couldn't find a human donor for a baby with hypoplastic left heart, so implanted a baboon heart. Didn't work too well, okay? But heart transplantation. So finally, it took a surgeon from Children's Hospital of Philadelphia, Dr. Norwood, to say, you know what, transplant, it may be an option, but there's got to be something we can do surgically. So let's look at hypoplastic left heart here and look at the circulation, okay? Blood goes from the inferior and superior vena cava, right ventricle, out the aorta, out the pulmonary artery to the lungs, but also across the ductus, filling the aorta. That's why they get so sick when the ductus closes. There's no other way for blood to get to the aorta. That's why prostaglandin helps them so much. So in a series of operations, here's what Dr. Norwood did. He said, there's no aortic valve, no aorta? Fine, I'll build one. Comes out of the right ventricle. Forgive me, but at least you have an aorta. Okay? So now there's a nice aorta coming from the right ventricle. All right? And pulmonary arteries out here floating. Okay? And I won't tell you how you get there, but the final procedure in the Norwood operation is to connect the superior and inferior vena cavas to the pulmonary arteries directly, the Fontan idea. So now look at the blood flow in this corrected hypoplastic left heart syndrome. Blood comes back from the lungs, nice and red, right atrium, right ventricle, out the aorta. Oh, that's good. Comes back from the vena cavas and goes to the lungs to get oxygen again. This is the Norwood operation for hypoplastic left heart syndrome. Again, if I took you out to a schoolyard and said, go ahead, pick out the 10 kids of the 100 who have had this done, you can't do it. Clearly, they need careful cardiology follow-up, and if you do formal exercise testing, not quite as normal as the other 90 kids in the schoolyard. Hypoplastic left heart syndrome. I want you to underline this page. This is an important one, okay? What did we learn? Heart failure in the first week of life, think of left heart obstruction, and you will be right 99% of the time. Coarctation, critical aortic stenosis, interrupted aortic arch, hypoplastic left heart syndrome. Heart failure at 4, 6, or 8 weeks of age, left to right shunts. What causes heart failure for the first time at 6, 8, 10-year-old? Something acquired. You weren't born with it, okay? It's myocarditis, rheumatic fever, endocarditis. We'll talk about those a little later. Okay? Final topic here. Valvular heart disease. Aortic stenosis, very important, very common. 7% of all congenital heart disease, male predominance for some reason. We talk about stenosis at the valve, aortic stenosis, below the valve, subaortic stenosis. And I remember earlier I told you about this narrowing of the aorta above the aortic valve, so-called supravalvular aortic stenosis associated with Williams syndrome. If critical, it's a left heart obstruction. It can cause heart failure at birth. Otherwise, quite asymptomatic. Clinical exam, there can be a click heard as that thickened aortic valve opens. Right after the first heart sound, a little click, and a rough systolic ejection murmur towards the right upper sternal border. With your hands, you might be able to feel a thrill in the suprasternal notch region. And on the EKG, there will be left ventricular hypertrophy. I want you to think about this because in a moment, we're going to contrast that with pulmonic stenosis. Here's the big difference. Aortic stenosis is very often progressive, okay? Meaning it can start mild as a newborn and then by mid-childhood be significant and by adolescence critical and severe, causing bad symptoms. It can present as exertional chest pain or syncope. The kid needs surgery. And children with anything more than mild aortic stenosis are prohibited from anything more than very soft kind of sports. So, in case you might get 8-year-old heart murmur, chest pain, near syncope while playing basketball, on exam, harsh systolic murmur, right upper sternal border, thrill in the suprasternal notch region. And look at the left ventricular hypertrophy on the EKG. Remember, V5 and V6, big voltages. That's left ventricular hypertrophy. And look at the abnormal ST wave segments. Remember I said look at ST segments? That's LVH with strain. And your recommendation would be restrict from sports, refer for testing, and probably surgical correction or balloon dilatation. We can do that in the cath lab sometimes, of the abnormal thickened aortic valve. Keep that in mind as we discuss pulmonic stenosis, also pretty common. 10% of congenital heart disease. Occasionally it is so critical and tight that it causes cyanosis in the newborn. Otherwise, harsh systolic murmur, left upper sternal border, might feel a thrill at the left upper sternal border, and there can be a click also heard after the first heart sound as this pulmonary valve opens, makes a little snapping sound. But unlike aortic stenosis where the click is constant, in pulmonic stenosis on physical exam the click varies very much with respiration. And on the EKG you'll find right-sided findings, right atrial enlargement, right ventricular hypertrophy. Unlike aortic stenosis, pulmonic stenosis rarely progresses after age 2. So if you have mild pulmonic stenosis at age 2, you're probably going to be mild the rest of your life, unlike aortic stenosis. Now, if we are dealing with a child with significant pulmonic stenosis, if symptomatic, or if the right ventricular pressure is more than half of the left ventricular pressure, we'll probably intervene, sometimes surgically, but more and more commonly, just, again, taking a balloon in the cath lab, opening up that stenotic pulmonary valve with a great degree of success. So here they are side by side. Okay, I'll probably put a little star on this page, too. Systolic murmur, right upper sternal border, aortic stenosis. Left upper sternal border, pulmonic stenosis. Thrill, suprasternal notch, aortic stenosis. Left upper sternal border, pulmonic stenosis. EKG, LVH for aortic, RVH for pulmonic. Clicks, yes, constant for aortic stenosis, variable for pulmonic stenosis. Aortic stenosis, often progressive. Pulmonic stenosis, almost never after age 2. Aortic stenosis, worry, because there's a risk for sudden death with activity. And with pulmonic stenosis, almost unheard of. Very important to understand aortic and pulmonary stenosis. How about leaking aortic valves, aortic regurgitation? What are the etiologies associated with aortic insufficiency? Congenital, abnormal aortic valve, okay. Rheumatic fever, that has eaten the aortic valve. Endocarditis, that has eaten the aortic valve. Marfan syndrome, fibrillin abnormality, gene test available. Physical findings in aortic insufficiency, bounding pulses, very easy to feel because the left ventricle shoots out enough blood to fill the circulation, knowing that some's going to leak back into the left ventricle. Big stroke volume. And this diastolic decrescendo murmur at the left midsternal border as the blood leaks back into the left ventricle from the aorta. The aortic insufficiency jet, as it enters the left ventricle, look up here, you'll understand it, sometimes doesn't let the mitral valve open enough. So normally the mitral valve likes to do this, but if the aortic insufficiency jet doesn't let it do that, you'll get a relative mitral stenosis. Some cardiologists will tell you, I think I hear a little mitral stenosis too. Okay, it's not really mitral stenosis, it's just that the mitral valve can't open, so-called Austin Flint murmur. And this happens to be an MRI of a 9-year-old boy with Marfan syndrome. Notice the dilated aortic root. Okay? Notice the jet of aortic insufficiency. Fibrillin gene testing available. It's supposed to be pretty good, I understand. Okay? And this is one of the major causes of aortic insufficiency in childhood. Almost there, guys. Watch for signs and symptoms of exercise intolerance. We monitor LV function. We may use some medications to help unload the ventricle, okay? But if any of these are failing, we will surgically intervene to reduce the aortic insufficiency, sometimes replacing the valve. Our goal, preserve left ventricular function. Mitral valves can leak too sometimes. They can leak because of congenital reasons, like a cleft in the mitral valve. Just like the aortic valve, they can be eaten away by endocarditis or rheumatic fever. And think of mitral prolapse and the association with Marfan syndrome and sometimes Ehlers-Danlos syndrome. Okay, here's an echocardiogram, the left ventricle, left atrium, and you can see a little blast of mitral insufficiency here. And on physical exam, you would hear a regurgitant, blowing systolic murmur at the apex. If it's severe enough and so much blood goes back into the left atrium that it comes across the mitral valve with a noise, that's called the Carey-Coombs murmur. Okay? And if it's mitral prolapse, you're going to hear mid to late, early mid systolic clicks, which change with position. Management of mitral insufficiency is extremely similar to aortic insufficiency. Watch for LV function or symptoms. Intervene if you have to. Finally, I think tricuspid insufficiency. When do we see it? In the newborn period, and sometimes in stressed newborns, they get papillary muscle dysfunction and the tricuspid valve will leak. Endocarditis, the tricuspid valve can be involved. AV canal defects, the endocardial cushions form the tricuspid valve, so that can cause insufficiency. And Ebstein's anomaly. I'll show you a picture in a second. Remember the association of Ebstein's anomaly of the tricuspid valve with lithium. Findings, the same kind of blowing systolic murmur that you hear with mitral insufficiency, but right here, right over the tricuspid valve, right at the right lower sternal border. Enlarged liver, enlarged jugular venous distension if severe, okay? And the chest x-ray, EKG, right atrial, and right ventricular enlargement. Tricuspid insufficiency. Here's Ebstein's anomaly. Here you see the displaced tricuspid leaflets displaced way down into the right ventricle, causing severe tricuspid insufficiency, severe cardiac enlargement. For the neonatologist, not a lot of things will present with this kind of a heart in the newborn period. Tricuspid Ebstein's is one of them, okay? Remember the association with lithium, okay? Lastly, I want to conclude this session by mentioning the problem of vascular rings and slings and other things, okay? So a 2-month-old baby, this is prime stuff for the boards, who comes in with chronic respiratory stridor and dysphagia may have a vascular ring such as this one, which is a double aortic arch, okay? And consider any kind of imaging modality to try to make the diagnosis. Sometimes good radiologists can tell you with a barium swallow. Usually another imaging modality is requested by surgeons before intervening. But from constriction of the airway and the esophagus, remember, a case, any baby with chronic stridor, chronic dysphagia, think of a vascular ring. We're talking about double aortic arch like this. We're talking about pulmonary slings where the left pulmonary artery comes off the right one and goes between the trachea and the esophagus, and other vascular rings, but important for the boards. All right, we did EKGs, we did rhythms and arrhythmias, and then we did congenital heart disease. That's the biggest, most difficult block, even though I hope you will, when you look back on your notes, see that the concepts presented are pretty straightforward. And now we're going to go on to some other fun topics, including acquired heart disease. Then we'll finish up with office-based cardiology. Okay? Here we go. We talked about rheumatic fever once or twice already in terms of destroying mitral and aortic valves. It can destroy other valves as well, but I want you to know the basics of rheumatic fever. Inflammatory condition following a group A strep infection. It went away for a long, long time, and so the people who trained in the 60s and 70s never saw it. And then all of a sudden it popped back up in the 1980s. Initially Salt Lake City, Utah for some reason. And there was another little mini epidemic, and I'm going to predict that a lot of people in this room have seen it. Can we see the hands again? Who's seen it? Yeah, look at that. Amazing. So I'm telling you that 30, 20 years ago, you wouldn't have gotten a single hand go up. So it's back, okay? And we'll talk about why. We know that there are individuals who are predisposed to rheumatic fever, and there are certain B-cell alloantigens that have been detected in over 70% of patients who get rheumatic fever following a group A strep infection. This is interesting because it's hard to believe, okay? But this is from military data, and since half of our residents are from the United States Air Force, We looked this up in the military literature, and this is what's stated. Among military recruits, 3% who get a strep infection get rheumatic fever. Sounds high, doesn't it? Think of all the kids who you see with strep infections but that's the answer on the boards, 3%. Okay? And as I mentioned, what happens here is antibodies against strep antigens cross-react with human heart tissue. So, antibodies against the protoplast membrane of the strep hits the sarcolemma of the heart. Antibodies against the M protein moieties hits the heart muscle itself. And the famous one is antibodies raised against the carbohydrate moiety attacks heart valves. It's one of the few entities in which there is a true pathognomonic finding on pathology, the famous Aschoff body, giant cells palisading, whatever that means, on microscopy. You know, if you think about some other diseases that have pathognomonic pathological finding, rabies and Negri bodies, there's not a lot of them, okay? But rheumatic fever is one of them, the Aschoff body. So the new epidemic was different. Here's will you raise your hands? In the old days, preceding sore throat was common in the history, not with this new epidemic. In the old days, it was only disadvantaged socioeconomic groups because of crowding that got rheumatic fever. Now it's equal opportunity for everybody. And there even may be some subclinical cases of rheumatic fever out there that we're learning about through serologic testing. This deserves the asterisk, the yellow marker, whatever you want to do, the Jones criteria, how we diagnose rheumatic fever. There are major and minor criteria. The major criteria include polyarthritis, big, painful joint, big joints mostly, extremely painful joints, migratory. The elbow will hurt and then it'll go away, and then the knee will hurt and it'll go away. Carditis, mitral insufficiency, aortic insufficiency, myocarditis, pericarditis, chorea. Okay? So for some reason, about a year or two ago or three, we saw a lot of kids in clinic coming in doing this. Sydenham's chorea. Okay? That's rheumatic fever. Most common cause of chorea in a kid. Right? Okay? Subcutaneous nodules. I'll show you a picture. They're rare now. And the famous erythema marginatum rash, which I've never seen. Very uncommon now for some reason. The minor criteria to diagnose rheumatic fever: elevated sed rate, first-degree heart block, the increased PR interval on the EKG, fever, arthralgia, and a prior history of rheumatic fever, plus evidence of a prior strep infection. Okay? 2 majors, or 1 major and 2 minors, and you got it. That's how we diagnose rheumatic fever. And, you know, these are the official numbers, but I'm going to disagree with them a little bit. Polyarthritis occurs, I'm going to say, 80-90%. Okay? Polyarthritis and carditis, 60%. I mean, the first two are the most common presentations. There are kids who come in with just carditis, and chorea is rare, but when it occurs, it comes in little epidemics, okay? Usually it's the teacher who makes the diagnosis, or previously really good students, all of a sudden not a very good student. Okay, in clinic, the kids will try to hide the movements. They'll try to hide it. They're a little embarrassed, you know? And if you just give them a pencil and paper and say, write your name, they can't, okay? Chorea. And I mentioned the rash, erythema marginatum, and the subcutaneous nodules, almost gone, almost not seen anymore. The old-time clinicians saw this absolutely all the time. Here's a picture of a heart valve, and this is a rheumatic nodule on the heart valve. If you were to slice that and put it under the microscope, you would see the Aschoff body. We can see these by echocardiography sometimes. Okay, so here is an echocardiogram, left ventricle, left atrium. You can see this child has a big blast of mitral insufficiency. The heart's a little enlarged on X-ray, a little bit of pulmonary edema, perhaps. And on this echocardiogram view, you can almost see those little nodules on the mitral valve. You see the little lumpy, bumpy things on what normally is a very thin structure. So sometimes we can see these by echo. This is the rash of erythema marginatum. It's on the trunk, serpentiginous, not easy to see. And if you see it, call your friends immediately because they're not going to believe you. Okay? And again, I have not seen this. Okay? Subcutaneous nodules, however, I saw once. And these are typically bumps on the extensor surfaces of the arms and the legs, suboccipital. Okay? I thought I was a resident. I thought I did a really good exam on a kid with rheumatic fever, and the kid goes, "Doc, come back here. What's these bumps?" So on rounds, I said, "I detected subcutaneous nodules." Oh, my God. One of my hero moments, one of my few hero moments. Okay? Subcutaneous nodules. Okay, laboratory findings. This is important. Elevated sed rate. But don't count on a positive throat culture. Often negative. Elevated white count, yes. Hematuria occasionally. There is, in rheumatic fever, we can see a little bit of hematuria from time to time. And what we expect to find, if the throat culture is not positive, which it often won't be, is good, hardcore, solid serologic evidence of antibodies against the strep. So anti-ASLO, anti-streptolysin O, or DNase B, or anti-streptokinin. 95% of the kids should be positive, demonstrating a prior strep infection. Treatment of rheumatic fever. For arthritis, aspirin, high-dose aspirin. I want you again to understand that the arthritis of rheumatic fever is miserably painful. The kids cannot even stand a bed sheet on their knees or on their elbows. Give them aspirin, come back a few hours later, they are so much better. Also remember, the arthritis of rheumatic fever does not deform the joints, unlike, I don't know, rheumatoid arthritis or septic arthritis. Okay? Never deforms the joints. Carditis. For mild carditis, meaning a little bit of mitral insufficiency on exam, bed rest, and aspirin will suffice. For moderate carditis, now we're talking about cardiomegaly, maybe a little pericarditis, bed rest, a short course of steroids, followed by a long course of high-dose aspirin, and obviously for severe carditis, ICU, prednisone 4 to 6 weeks. Don't forget to taper it, and we'll use whatever cardiac medications we have to control the heart failure. Okay? So that's the treatment of rheumatic fever. It's really symptomatic treatment, really. How about the kid who comes in doing this dance? Okay? All right, Haldol or benzodiazepines are often sufficient. We'll always do an echo or listen very, very carefully, because we know even with those kids with chorea, who tend to come in months after a strep infection, heart still can be involved. Okay? So we look for carditis in children who present with chorea. Sydenham's chorea, by the way, that's the name. Okay, so you had a kid with rheumatic fever, he's all better now. What do? You want to prevent a recurrence of rheumatic fever. And if you do the right thing, you will lower the attack rate to way, way under 1%. The best way, every article, to prevent recurrences of rheumatic fever is to give penicillin G, penicillin, LA bicillin, once a month. Actually, every 28 days is the best. Okay? That's the best way to treat recurrences of rheumatic fever. Oral pen VK, okay, but not as good. Okay? Sulfa drugs can be used for patients allergic to penicillin. But remember, sulfadiazine prevents strep infections, but you cannot treat a strep infection with sulfadiazine. Little subtlety there. Okay? So that's the prevention of attack. Okay? Rheumatic fever, I've seen kids die from it. So there's a mortality. And how much residual heart disease they're left with depends on the severity of the initial attack. So kids with horrible carditis, cardiomegaly, aortic, mitral insufficiency, out of control, tend to end up with some degree of mitral aortic insufficiency. Okay? Repeat attacks, if they do get another attack, it tends to mimic the first one. So a kid who had bad carditis is going to get bad carditis if we don't prevent the recurrence of rheumatic fever the way I just described. Okay, that's an overview of rheumatic fever. Okay, let's talk about endocarditis a little bit. We divide endocarditis into primary and secondary endocarditis. Primary refers to infection of native heart valve tissues, but because of increasing heart surgery, prosthetic valves, conduits, and things, we have used the term secondary endocarditis to describe infections of the prosthetic materials. Okay? Endocarditis is a big player in pediatrics. Okay? So when you look at hospital discharge data, endocarditis, peds is way, way up there. Okay? Over 20% of cases occur in pediatric population. And there's been increasing numbers of hospitalizations for endocarditis because more children are surviving heart surgeries, more kids are having artificial thises and artificial that's put into the heart. Okay? So that's why endocarditis has not really gone away. If anything, it's as prominent as previous decades. 17% occur in kids who have no prior history of a heart defect. All right, they just come in off the streets with positive blood cultures and a history of endocarditis. 43% do come in patients with postoperative histories. Okay, so these are the kids who survived heart surgery and or have prosthetic materials in place. There are certain high-risk lesions. You need to know them: Tetralogy of Fallot, VSD, and aortic stenosis. Okay, so the 30-year risk for a kid with aortic stenosis is upwards of 10%. What's happening here with these heart lesions is that there's a jet lesion that injures the endothelium somewhere in the heart. Once the endothelium is denuded, platelets can start being attracted to that site, and then organisms in the bloodstream, whether from unknown causes or for dental manipulations, stick into that platelet fibrin mesh, and now you have an infection. And there's an immunologic component to endocarditis. So circulating immune complexes are part of the pathophysiology and can cause renal disease and hematuria that we'll talk about in a second. What are the bugs? In pediatrics, strep viridans and Staph aureus are equal offenders, okay, and account for 90% of cases. Gram-negative, a little bit, okay. Enterococcus, which is a big player in adult endocarditis, for some reason is almost unknown in pediatrics. And another difference from adult cardiology is we don't buy into the culture-negative endocarditis, okay? The adults will make that diagnosis from time to time. We expect a positive blood culture in a child with endocarditis. If you get staph epi in a blood culture in a postoperative child with fevers and shaking chills, and don't assume it's a contaminant. So staph epi can definitely be a pathogen in a child with a prosthetic device. And of course, fungal endocarditis. That's another issue we deal with in pediatrics. Can be seen in immunocompromised hosts. And I think probably everybody has seen a premature baby with a central line have a vegetation that's probably is fungal. Okay? Little special pediatric presentation of fungal endocarditis. So clinical diagnosis: fever, new or changing heart murmurs or heart failure in a previously well kind of person or somebody stable after heart surgery. Petechia, look for petechia, okay? Star that one. They're there. And splinter hemorrhages, splenomegaly. You can find those in endocarditis. Roth spots on the retina, Janeway lesions, Osler nodes. I've never seen them. Tommy tells me he's seen them. I'll show you pictures though, okay? Laboratory findings: expect mild anemia, elevated white count. You can see a positive rheumatoid factor. Remember, there's an immunologic component here in the pathogenesis of endocarditis. And hematuria due to immune complex deposition in the kidneys. And as I mentioned before, we expect a positive blood culture in endocarditis in pediatrics. Splinter hemorrhages, you can see those. And petechiae. Okay, and here conjunctival. These I've seen in kids. I have not seen these painful Osler nodes or Janeway lesions in children. Okay, but you have pictures of them if you want to look at them. And again, what's happening is the formation of a vegetation first, a fibrin platelet mesh, which then becomes infected with bacteria. And here is a picture of a bicuspid aortic valve. You see one leaflet and two leaflets, and then you can see how easy it is sometimes for us to spot a vegetation by echocardiography. Treatment is antibiotics, 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 okay? 4 to 6 weeks based on cultures and sensitivities. Be aware of the fact that aggressive Staph aureus infections and some fungal infections, many fungal infections, require surgery. And the surgeons are not happy about operating on a very sick kid with Staph aureus, endocarditis, or fungal endocarditis, but sometimes you have to save a kid's life. I'm not going to go over this table at all. Don't ignore it. Obviously, the antibiotics are based on cultures and sensitivities. Okay, now there are complications of endocarditis that as cardiologists we're watching for, okay? So you start antibiotics, and what you're looking for are possible complications such as heart block. That's an abscess of the conduction system. Heart failure, which you might have to treat due to horrible mitral, aortic, or other valve insufficiencies. Multiple major emboli. If a kid is just throwing emboli in spite of the antibiotics, the kid needs surgery. Okay? If there's a myocardial abscess, I've seen these. Okay? All of a sudden, the myocardium around the aortic valve starts looking liquefaction by echo, needs surgery. Or persistent sepsis, meaning in spite of giving good antibiotics, we're still getting positive blood culture, positive blood culture, positive blood culture, positive blood culture. Time for surgery. So this is not a fun disorder, okay? And this has a high case fatality rate. All right, so be scared when you're taking care of somebody with endocarditis. All right? Now, I think you all know that there are new guidelines out about how to prevent endocarditis. Remember in the old days, anybody with any kind of real heart problem, any heart murmur, septal defect, aortic stenosis, got antibiotics before dental work, GI procedures, GU procedures. We don't do that anymore. Okay? And these guidelines have been out long enough that the boards has picked these up. Okay? So who now do we give antibiotics before dental work to? Only these kids. Kids with prosthetic heart valves. Kids with a previous history of endocarditis. Unrepaired cyanotic congenital heart disease gets antibiotics. Completely repaired congenital heart disease with prosthetic material or a device for the first 6 months after surgery. And then certain cardiac transplant patients. But notice what's not there. VSDs, aortic stenosis, pulmonary stenosis, mitral insufficiency. It's gone. No more endocarditis prophylaxis. Okay? So we only give endocarditis prophylaxis, which means a dose of antibiotic before a procedure, such as a dental procedure, only to those conditions listed on the previous slide. No one else needs endocarditis prophylaxis. And, no antibiotic procedure, medication given for GU or GI procedures. Okay? So very different, but I think this has been out long enough that you guys are all probably very, very familiar with it. But for those of you who have been out 5, 6 years, know about this. Very important. Okay, anybody ever see a kid like this? Yeah, okay, everybody's seen this. See, when I was a resident, we first heard about this, a strange disorder in Japan. We had not seen it yet, okay? And then all of a sudden, California and San Francisco started seeing it, and then the Midwest, and then everybody had experience with Kawasaki's disorder. And diagnosis of Kawasaki's disease, 5 days of fever plus 4 of these 5 features. Cervical adenopathy, non-exudative conjunctivitis, non-vesicular rash, erythema, right? You've all seen it. Hands and feet are bright red, and the mucosal involvement as seen in this slide. You can almost spot them across the room almost, you know. Laboratory findings, elevated white count, anemia, sed rate, sterile pyuria, very common, a mild bump of the liver enzymes on a chemistry, very, very common. Little decrease in serum albumin all the time. It's really there. This is really out there. And obviously thrombocytosis after the acute phase, platelets start to rise, 600,000, 800,000, 1 million, 2 million. I think you're all familiar with that. From the cardiology point of view, what are we worried about? We're worried about this, dilatation, aneurysm formation of the coronary arteries. So you guys are used to treating this. We didn't know how to treat this when it first came out, and 20% of the kids had aneurysms. Okay? More common in young boys, more common in those very high sed rates and fevers. These aneurysms occur right where I'm showing you here, right near the aorta, so they're kind of easy to see by echo. And many of them resolve spontaneously over 2 years, although giant aneurysms, those more than 8 millimeters in diameter, are the ones that are associated with death, myocardial infarction. And we've come a long way preventing myocardial infarctions in children with Kawasaki's. I'll show you that in a moment. But there are other cardiovascular complications of Kawasaki's disease. Many of them have a little bit of pericarditis. They can have aneurysms of other vessels. So it's not just the heart, guys. It could be renal vessels, aneurysms of axillary arteries, intercostal arteries. So I'll always ask, examine a kid thoroughly and follow up and make sure there are no aneurysms of peripheral vessels that I can detect. Heart failure is rare, but LV dysfunction and dilatation is quite common. Occasionally, we will see mitral insufficiency as a complication of Kawasaki's disease. Now, here's the difference treatment has made. So in the 1970s, when I was sitting where you're sitting, some of you, 2% of them died from a myocardial infarction. And now, with treatment, the mortality rate is way, 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 way below 0.3%. So this is the impact of IVIG, immunoglobulin intravenous. Causes of death, mostly myocardial infarctions, thrombosis of those coronary artery aneurysms, heart failure, and then some, remember I mentioned these other peripheral aneurysms that can develop, rupture of, can cause a small number of deaths in children with Kawasaki's disease. Treatment you're familiar with, IVIG, okay, very effective. We also initiate treatment with high-dose aspirin for its anti-inflammatory effects, but we'll give high-dose aspirin only until the fever starts to decrease, the sed rate begins to decrease, and the platelets start to greatly increase. Then stop the high-dose aspirin and go to your low-dose antiplatelet doses of aspirin. You've got to do that to prevent thrombosis of any coronary aneurysms or other aneurysms that might be present. High-dose aspirin does not do a good job interfering with platelet function. Low-dose aspirin does. Don't forget to make that switch. Okay, that was a little review of Kawasaki's for you. I hope that was helpful. Case presentation. 16-year-old girl with 1 week of increasing shortness of breath. Past medical history benign, but a little gastroenteritis 2 weeks before. Tachycardic, pulse 120, S1, S2, S3, S4, gallop rhythm, rails, and large liver. Heart failure. Remember, heart failure in the first week of life, left heart obstruction. Heart failure in the first 4, 6, 8 weeks of life, left to right shunts. Heart failure in the older child, something acquired. And given the history here, this is a case of viral myocarditis. Here you see the cardiomegaly, and on biopsy, which we don't really do a lot of for reasons I'll talk about later, you can see the lymphocytic infiltration of the myocardium. So viral myocarditis can present with heart failure, but I've also seen it present with horrible ventricular arrhythmias. Coxsackie-B is a big player, echovirus, others, many others. The diagnosis is made clinically and by echo. Here you have a normal-sized left ventricle, which can contract normally. Here, a grossly dilated left ventricle with poor function. I mentioned biopsy only occasionally because myocarditis can be very spotty. And so to take a catheter and try to biopsy the heart, you're just as likely to miss the myocarditis as to get it. So we only do that if we're really, we don't know what's going on here. Let's get multiple biopsies, okay? The differential diagnosis when you see a dilated, poorly functioning heart, I'm going to help you here, I'm not going to confuse you, is with something called dilated cardiomyopathy, which is more of a chronic condition. And I'll tell you about the etiology of dilated cardiomyopathies in a moment. Treatment, hey, inotropic support, diuretics, afterload reduction. And in pediatrics, there's a little bit of literature saying that intravenous immunoglobulin may be useful in the treatment of myocarditis. The adult cardiologists don't think that's the case, but we will do it, and there is some literature that you might end up with a little better preserved LV function if you give these kids IVIG. Prognosis is pretty good, okay? So 70% will improve dramatically, and paradoxically, kids with what we call fulminant myocarditis, which you would think would be, forget it, they do pretty good. If you take care of them, they really get better for some reason. However, there are 30% who will go on to develop chronic heart failure, dilated cardiomyopathy. So one of the causes of a chronic, dilated, poorly functioning heart is a burned out myocarditis. But there's other causes, and I'll show you those in a second. Okay, and for those who do persist with chronic heart failure, treatment is maybe digoxin, although that's falling out of favor, afterload reducing vasodilators, ACE inhibitors, enalapril, carvedilol, beta blockers maybe. So paradoxically, you have a child with a poorly functioning heart, but you give them a beta blocker to try to temper the evil effects of elevated catecholamine levels on the heart. And of course, cardiac transplantation if you have to. Dilated cardiomyopathy, let's just talk bases about that for a second. I mentioned it could be the cause of a burned out myocarditis. But there are other genetic causes. There used to be something called endocardial fibroelastosis. Babies were born with these poorly functioning hearts with this fibrosis of the endocardium. Don't see that much anymore. But there are autosomal recessive mutations of proteins that can present with familial dilated cardiomyopathy. So dystrophin is one such protein in muscular dystrophy. And dystrophin, like many of the proteins that cause dilated cardiomyopathy, are proteins that link the sarcolemma with the extracellular matrix, okay, to contractile proteins. So dystrophin in muscular dystrophy is an example. Some of the metabolic causes of a dilated, poorly functioning heart: glycogen storage diseases, carnitine deficiencies, hypothyroidism. So there are certain metabolic causes if you are presented with a child with a chronic, dilated, poorly functioning heart. Mitochondrial diseases can involve the heart. There are nutritional causes of a dilated cardiomyopathy: beriberi, the deficiency of thiamine, and starvation. And there are drugs. So anthracyclines, you're all familiar with adriamycin, donomycin effects on the heart. We monitor them very carefully to make sure we're not causing a dilated cardiomyopathy. And when I was a resident, we used chloramphenicol all the time in the treatment of neonatal sepsis. And if you gave too much, you might get a dilated cardiomyopathy. So this just gives you an overview of what to think about when you're facing a child with a dilated, poorly functioning heart. I hope that's helpful. Okay, case presentation. Fair game for the boards. Almost expect this. 4-year-old presents with fever, chest pain, and shortness of breath. Elevated heart rate, elevated respiratory rate. Jugular venous distension increases when the kid breathes in. The blood pressure is 100/66, but when the kid takes a breath in, it drops to 80/66. Pulsus paradoxus. Muffled heart tones, rales, hepatomegaly, and edema. This child has pericarditis. Look at the x-ray. Pericarditis with a pericardial effusion. Doesn't it look like a bag of water that you set on a table? Okay, has a very characteristic appearance on chest x-ray. And we can do an echocardiogram, and here's the left ventricle, and you can see the water, the fluid, surrounding the heart. Pericardial effusion. Everybody see that? Okay. Let's talk about pericarditis in the pediatric patient. Multiple etiologies. Can be bacterial. Strep pneumo, H flu in the old days, TB, others, staph. Okay. Viral, very common. Coxsackie B, adenovirus, influenza, EBV. Collagen vascular diseases can cause pericarditis. There's something called post-pericardiotomy syndrome. A kid goes for heart surgery, does great, and then 2 weeks later has pericarditis. It's an immunologic reaction. Post-radiation, post-trauma, blows to the chest, the steering wheel in a car accident can present later with pericarditis, neoplasm, and uremia. And the treatment of pericarditis depends on, well, bless you, what the etiology is. Signs and symptoms: chest pain, respiratory distress, pericardial friction rub. Okay, if you take your hair and rub it near your ear, that's what it sounds like. Okay, that's exactly what it sounds like. Poor perfusion, that's a sign of tamponade. I mentioned pulsus paradoxus, where normally when you take a breath in, your systolic pressure falls 6, 8, maybe millimeters of mercury, 10, maybe. But if it falls below that, that's abnormal, and that's called pulsus paradoxus. I saw one woman whose systolic pressure went from 90 to 0 when she took a breath in. That's how distended the pericardial sac was, inhibiting fluid blood from returning to the heart, okay? And this jugular venous distension that I mentioned, again, the heart can't fill. This jugular venous distension that increases when the person takes a breath in, that's called Kussmaul's sign. All of these are signs of tamponade. Hepatomegaly and edema can be presenting signs as well. If there's tamponade, stick a needle in and evacuate the fluid. You can do it. The big effusions are easy. Almost can't miss them. Don't hesitate, okay? So if you don't have to wait 3 hours for your cardiologist or surgeon to come in. Just do it, okay? Get the fluid out to save a life, okay? The chronic therapy depends on what the etiology is. So for a viral pericarditis, aspirin, bed rest. Bacterial, antibiotics, but you also have to stick a drain in for several days. If you don't put the drain in, you're going to lose. Uremia, the treatment is dialysis. Rheumatic, collagen vascular disorder, steroids. So the chronic treatment depends on what the underlying etiology of the pericardial effusion is. Okay, finishing up. Office-based cardiology. Stuff that comes into your office and then to our clinic, sometimes. Chest pain. Notice where cardiac causes of chest pain is on this list. So why do you send them all to us? Okay? Musculoskeletal, pulmonary, pleuritis, GI, it ain't cardiac usually. Okay? But I'll talk about what some of the cardiac issues are in a child with chest pain. Okay, now we're going to learn something. The most common cause of chest pain in children is intermittent chest wall pain in an otherwise appearing normal well child. It is sharp, it is 10 out of 10, and the kid can't breathe. And it is benign. And it is called precordial catch syndrome, okay? Kids come into the office loaded with laboratory testing, okay? But really, laboratory testing should only be done guided by history and physical. So fever, chest pain, cough, chest x-ray, okay? Otherwise, not needed. Chest pain that occurs mostly at rest, intermittent, pleuritic, is extremely common. It is totally benign, and no laboratory testing is needed. So how many in this room have had horrible, sharp, intermittent chest pain, couldn't breathe? Let's say it, typical 40%. Okay? This is common, all right? All right? Nothing needs to be done. So you tell the mother, so is the chest pain extremely severe? Uh-huh. Child can't breathe? Correct. Don't worry about it. All right? All right? All right? All right? As I said earlier in the talk, chest pain that occurs mostly with exertion, we worry a little more about. Okay? It's still usually nothing, but we may do an evaluation of a child with chest pain or syncope that occurs mostly with exertion. Okay? Are there cardiac causes of chest pain? Of course. But really, just by looking at the kid, physical exam, looking for stigmata and murmurs, acutely ill appearing, you'll pick up the cardiac causes. The few that I've seen, the myocarditis, the pericarditis, one kid whose prosthetic aortic valve was dehiscing from the aortic root, you just look at them across the room and you can see them clutching their chest and being ill appearing, okay? So most of these you can detect clinically or with a stethoscope. So left ventricular outflow obstruction, severe aortic stenosis, you're going to detect that with a stethoscope, okay? Mitral prolapse, murmurs and clicks, myocarditis, they don't look well, they have friction rubs, they're sick, et cetera, okay? So these can cause chest pain, but the most common cause of chest pain is that benign form that we just figured out 40% of the people in this room have. Syncope, please evaluate, okay? Let's do the same test. Experiment. How many people in this room have ever fainted once? Oh, it's the same. That's different 40%. Okay, great. Good. I feel sorry for the few of you who have both fainted and have had chest pain, okay? It's extremely common. The most common etiology is vasovagal fainting, also called neurocardiogenic fainting. To the parents, I use the word simple fainting. They kind of like that. All right? Extremely common. more than 80% of pediatric fainting. The diagnosis by history is often sufficient. Standing or getting up in church for some reason. Church is big offender. Or in school, dizzy, sweaty, pale, tunnel vision goes down. Okay? We think the pathophysiology goes something like this. A little dehydrated, you stand up, blood drains from the chest, enters the abdominal capacity vessels in the legs. Heart gets a little empty, we think. Then the heart does this little vigorous sympathetic thing, okay, which activates receptors in the heart wall, sending a signal up to the brain. The brain goes, why are you doing that? And sends down a powerful vagal discharge to stop the heart and cause hypotension. We think that's what's happening in simple vasovagal syncope. Now, the tilt test. Please do a tilt test. No. Tilt test should not be needed for the routine diagnosis of neurocardiogenic syncope. It should only be used if you have a question. Has anybody ever seen a tilt test? It's one of the most absolutely dramatic things you've ever seen in your life. It's very high tech. Here's what we do, okay? You charge a lot of money, okay? But to watch it is one of the most fascinating things you've ever done. So heartbeat, 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 asystole. And you're sitting there. You go, asystole, no heartbeat, no blood pressure, no respiration, dead, okay? And you don't call a code, and you don't do CPR, you just tilt him back, and he comes alive again, okay? Okay? So that's the tilt test, okay? We only use it if we are really not quite certain what's going on, okay? It's amazing to watch, okay? Treatment, really high tech, fluid, 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 okay? So generally 64 ounces a day I recommend for some of the kids. And I like the sports drinks because they have a little salt in them. And I say to the mom, I say, you know how we tell you don't put salt in your food? It's no good for you. Put salt in this food, okay? Often that's enough to cure them, diminish their symptoms. If they do have to go on to drugs, mineral corticoids like fludrocortisone, very good, once a day. Florin-F, 0.1 milligrams per day. We used to give beta blockers because we remember the part where the heart's beating hard, and it doesn't work that well. For kids who are continuing to have fainting syncopal episodes, there are alpha agonists that we can prescribe that just maintain the blood pressure, vasoconstrictors, okay? So there are other drugs you can use, but again, I just want you to know that most common cause is vasovagal syncope responds really well to fluids and salt supplementation. Okay? Now, in the child with recurrent syncope, and again, if the syncope occurs with exertion, that's a red flag. At least get an EKG looking for some of the causes of syncope that are cardiac rhythm related, like Wolff-Parkinson-White syndrome. We showed you EKGs of that earlier. Long QT syndrome, I showed you EKGs of that earlier. And hypertrophic cardiomyopathy with a characteristic left ventricular hypertrophy on EKG. Again, I would reserve that for the child with recurrent syncope with exertion. Are there cardiac causes of syncope other than arrhythmias? Yes. But again, easily detectable by history and does the child look well and maybe a stethoscope. Okay? But the most common cause of syncope is that simple vasovagal syncope. Some funny associations with syncopal patients. You want to make sure they're not seizures. All the kids come in with EMS with hypoglycemia documented, which probably is not true. Migraines. A lot of the families talk about migraines in the family. And if you ask the families, there's often a family history of syncope, vasovagal syncope. They're psychogenic. We've seen it. And then breath-holding spells, okay? So remember, breath-holding spells, that's the 2-year-old toddler, gets angry about something, cries and screams, holds his breath, turns darkly cyanotic, falls to the floor, and has a seizure, and you tell the family, don't worry about it, okay? Okay? It is benign, okay? Honestly. Okay. A little serious here now, okay? Cardiovascular sports screening. Would you sign this slip so I can go play football? So I think you're all aware that there are cases of sudden death in high school, college athletes. And what are we supposed to do as pediatricians when asked to sign this permission slip? It's rare, but the more we start looking for this, it's not as rare as we used to think. We used to think a couple of times in the country per year. We now think it might be a couple of hundred per year in the country. Now, again, that's with millions and millions and millions of kids participating. But still, it may be a few hundred kids per year die. And when it happens, needless to say, our phones ring off the hook. Okay? And what are we supposed to do? Okay? These are the causes of sudden death in the child athlete. So, hypertrophic cardiomyopathy, abnormal, sick, thick heart muscle, a genetic disorder, is the number one leading cause of sudden cardiac death in the child athlete. The second most leading cause, and I'll show you pictures of these in a moment, is coronary artery abnormalities. And we'll get to commotio cordis in a second. The third most common cause is aortic rupture due to Marfan syndrome. Look how all the other causes are way, way below. So long QT, ion channel, aortic stenosis, myocarditis. Let's review the major causes again. Hypertrophic cardiomyopathy, big gorilla. Coronary anomalies, I'll show you which ones we're talking about. Something called commotio cordis, I'll talk about in a moment. And rupture of the aortic, Marfan syndrome. That's what causes sudden death in the child athlete. Commotio cordis, we used to think was exceptionally rare. What this is a blow to the chest. Either the most common sports are baseball, hockey. A blow to the chest during a very certain period of the cardiac cycle can cause an instant ventricular tachycardia, ventricular fibrillation, and a death that is almost unresuscitatable. We used to think it was rare, but by keeping registries going and seeking information, it has now risen to be the third most common cause of sudden death. I am now going to show you commotio cordis happening on a karate field. Okay? I am not doing this for shock value. I'm doing it because I want you to ask yourselves, would you know what had happened to this child? You're going to see two kids with karate. Keep an eye on the kid on the left and play. There's the blow. Okay, ventricular tachycardia degenerating into ventricular fibrillation, and it goes down. Okay? Two things about commotio cordis. What you do not see happening is CPR. Okay? You do not see CPR happening. So that's one of the problems with commotio cordis. Okay? That's why the history of resuscitation is so poor with commotio cordis. Okay? I wanted to show you that. Okay. The prevention of death from commotio cordis includes chest protectors during baseball, during hockey. Some people advocate the use of soft baseballs for college, high school athletics. And probably most importantly, defibrillators at every sporting event. Okay? Here are the three other large causes of sudden death in the United States. This is hypertrophic cardiomyopathy. This is number one. This is the big gorilla. Okay? Notice the thickened interventricular septum. Okay? Easily detected by EKG. Almost always shows left ventricular hypertrophy. Here's the coronary artery problem that I mentioned. This one's a little scary because the EKGs are often normal in history, sometimes abnormal. Here's a normal arrangement of the coronary arteries. Here's the aorta. Here's the right coronary coming and the left. That's normal. Here's the anomaly that causes sudden death. There's a single coronary coming off the aorta from which the left coronary branches. Notice how it passes between the pulmonary artery and the aorta. At rest, this is no problem. But with exercise, when your cardiac output doubles, triples, whatever, and the aorta and the pulmonary engorge, the coronary gets trapped in between these two engorged vessels, causes ischemia, arrhythmia, and death. Okay? And finally, the other important cause of sudden cardiac death in the high school college athlete is Marfan syndrome. And if you think all Marfan kids have the typical spidery fingers and tall, no. And the big wingspan, no. A little scary. Okay? Marfan syndrome. Okay, so what are you going to do about this? Currently, and I will tell you this is highly controversial, highly routine EKG echo screening of all children is not recommended in the United States. Okay. But I will tell you that in Italy, they do EKG screenings of all children. And they claim and present data that they have reduced sudden death due to hypertrophic cardiomyopathy substantially. In the United States, it's a matter of not just cost, but how to get EKGs performed and read accurately on the millions of high school and college athletes. I will tell you that a little community in our neck of the woods tried to do this, and it was a disaster with the false positives and the nonspecific SCT wave changes and the mild sinus arrhythmias all getting referred in for cardiology evaluation. But there are groups that say you must do EKGs on child athletes because you can easily detect hypertrophic cardiomyopathy and prevent sudden death. But what we do in the United States is targeted, and I know you all know this, targeted history and physical screening of all athletes, and if abnormal, send them to cardiology clinics. So, a history of exertional syncope, near exertional chest pain, excessive fatigue or shortness of breath. Okay? Family history of premature death or disability from heart disease in relatives less than 50 years of age. History of Marfan's, history of long QT, history of hypertrophic cardiomyopathy in the family. You've got to ask specifically. Physical stigmata of Marfan's, et cetera, et cetera. If any of these are positive, no sports participation until screened by a pediatric cardiologist. I do think that one day many of these disorders, so Marfan's in particular, definitely long QT, hypertrophic cardiomyopathy, I think will be part of a newborn screen. Okay? I think that's how that's going to get resolved. Or our engineers and computer people will design programs to look at EKGs performed out in the field in schools and with high precision refer those who need to be referred, not everybody with a slight wiggle on the EKG. Okay? Okay, cholesterol, lipid screening in children. Final topic. We're there, home stretch, third base. Okay? This has just changed. Okay? So I'm going to teach you both the old guidelines and what the new guidelines are. And please understand that these guidelines have just changed within a year, not even a year old yet. And sometimes it takes the boards a few years to figure it out. Oh, look at that. All right? So here we go. When we first decided that it would be useful, or we should, know something about children and their risk for cardiovascular disease, there were three strategies that were mentioned. One was universal screening. Every child should get a needle in the arm measuring lipids. And this was poo-pooed and rejected. It is now the standard. Okay? So that's the old poo-poo and the new, it's now the standard. Okay? There were those who said, don't stick a needle in any child's arm. If we were to just spend the resources and the money on healthy diets and playgrounds and PE in school and healthy lifestyles, we would get much bigger bang for the buck. And there were tremendous proponents of that strategy. And what we've been doing for many years, though, is a targeted screening, meaning putting the needle into the arms only of children that we determine to be of high risk. That's the bottom line here, okay? So I'm going to blast through these a little bit because they've changed, okay? So the old guidelines were put the needle into the arms and measure lipids only in children in whom there's a parent or grandparent less than 55 years of age who underwent diagnostic testing for coronary artery disease and was found to have coronary artery disease or had surgery or balloon angioplasty. Okay, we'll screen those kids. Screen them when there's a parent or a grandparent less than 55 with a myocardial infarction, stroke, peripheral vascular disease, or sudden death. Okay, I can follow those guidelines. Screen children if there's a parent with a total cholesterol greater than 240. Screen children if the family history is not known or there are other risk factors present, such as obesity, smoking. I mean, by now you're screening everybody, okay? Okay, but these were the guidelines that have been in place since the late 1990s, okay? The newest guidelines include the following. Healthy diet for all children greater than 2 years of age, okay? And this was very new, okay? And this was hit some raw nerves for some people. Low-fat milk is appropriate for high-risk infants, meaning a bad family history, after age 12 months. Very different, okay? Screen children after 2 years of age, but no later than 10 years of age. Fasting lipid profile is preferred. This was for high-risk kids, okay? If normal, retest in 3 to 5 years, okay? I'm going through this because I want to go here, okay? Here are the newest guidelines. Universal screening for all children, every child, age 9 to 11 years. For the high-risk kids, 2 to 8 years. Screen again, 17 to 21 years. That's the current recommendation because we think it's so important to detect children with dyslipidemias because of the known importance and association of elevated LDL lipids and the development of coronary artery disease. Okay? Once we find a child, what the couple of slides before this one show is that once you identify a child with an elevated LDL, diet, exercise, low-fat diets, but if that doesn't work, we are now much more aggressive, suggesting the implementation of pharmacologic therapy, and more commonly, the recommendation is the first drug of choice should be a statin. Very, very different. Okay? So I wanted to present the old and the new thoughts about screening children for elevated lipids, dyslipidemia, and the importance of it and why we are doing it a little differently now. I wish you well on your board exam. Had a great time. Thank you very much.